Sladden. I'm an HIV advisor with UNFPA, the Population Fund, and it's my pleasure to welcome you all to this fourth seminar of the Key Populations Community Practice, and the first one for this year. And we have a very important topic that we've selected for everyone today, which is really going into some detail about how we work with young key populations who are often extremely neglected and lack access to services. They often lack knowledge and skills and experience that some older people and within key populations are more able to assist themselves, and young key populations, sometimes there are no services for them, and there are even some barriers to service providers providing services. So today we've got a very good panel of speakers, and we're going to really go into why working with young key populations is a priority and what sort of services are needed for them. We're going to hear from some workers in the field, how young key population programs are implemented. And of course, we're going to hear from some young key population representatives themselves about nothing for us without us. Then we have a panel discussion with some people from various perspectives, and then we'll close. So I'll just hand over to Kerry for some brief housekeeping details. Thank you, Kerry.
Thank you very much, Tim. Karabo, if you just go up one slide, please. Colleagues, I want to, just to the cover slide, if that's all right. I want to just inform you that this webinar will be taking place in English. But if you look at the bottom of your screen, there is the option for you to select either French, Portuguese, Russian, or Spanish, if you prefer to listen to the webinar in another language. I also want to let you know that there's a question and answer tab or place where you can click, and I'd like to encourage people to please put their questions in the question box, as the panelists and presenters will be able to answer your questions in writing as we go through this webinar. I also want to encourage participants of this webinar to please introduce yourselves in the chat box. There's a chat box that you can also use, and you can just let us know who you are and where you are from. Since this webinar will be taking place in a number of languages, I just want to encourage the panelists and presenters to please kindly not speak too quickly. And if anyone is struggling with any of the interpretation or the speed at which people are speaking, to kindly let us know. This recording will be shared, as will the presentation and the slides. So please note that following this webinar, we will be able to circulate all of those to you. Thank you so much. Tim, back to you.
Thanks very much, Kerry. Just a quick housekeeping thing. Do you recommend we keep all question and answers to the end, or we will do it after each session?
Tim, I think we can do written question and answer throughout, but perhaps it would make sense to cluster it for time's sake a bit later on.
Okay, yes. All right. So if you've got a question, do write it in the Q&A section, and people will try and write back to you straight away. And then at the end, we'll have another Q&A session for some oral questions. So first of all, let's get straight into it. And we have a recording, first of all, from UNFPA and UNDP in our head office in New York, who are going to talk about the global evidence and the guidelines and the policies for working with and for young key populations. So if we can have Ilya Zhukov's presentation, please. It's a bit early in New York, so they weren't able to be here in person.
My name is Ilya Zhukov. I'm from UNFPA. In UNFPA, in HQ, I coordinate our global comprehensive sexuality education program. But before becoming a focal point on comprehensive sexuality education, I worked with UNFPA in different capacities from 2005, and most focus of my work was on sexual reproductive health and rights of young key population. So that's why it's a pleasure for me and it's an honor for me to speak today with you. I apologize that I do it with pre-recording video. Since it's like 4 AM right now, when you are watching me in New York, where I'm based, and last week, every night I started at 2 AM to join global symposium on comprehensive sexuality education, so it's a little bit too much for me to work overnight 2 weeks in a row. But let's go directly to the topic of my presentation. It's a very interesting topic, but at the same time, this topic is quite challenging. So, unfortunately, we still have relatively few data available about young key population and HIV risk. But those data that we have suggest HIV is more prevalent among young key populations. So let me give you just some examples of such data. Globally, in 2020, young people, including young people within key populations, accounted for 27% of new HIV infections. Among young men having sex with men, HIV prevalence has been estimated globally at 4.2%. Among young transgender women, the global estimate of HIV infection is 19%. In 2018, it was estimated that there were 300,900 young people aged 15 to 24 living with HIV in the Asia-Pacific region. In the same year, 82,000 were newly infected and 4,600 died of AIDS-related illness. What is also very important for us, talking about young key populations and HIV and sexual reproductive health and rights of young key population, it's to understand social and structural factors. Among them, age, the stigmatization of their behavior or sexual gender identity, and the lack of knowledge about ways to protect themselves. Sexual reproductive health and rights services are unavailable or too expensive for young people from key populations in many parts of the world. Age of consent, it's also one of the factors which doesn't allow young people from key populations to have access to HIV prevention services and information and commodities. And probably it sounds not important, but what we know this from our focus group discussions and working with young key populations, that location and opening hours of services are also very important factor, because very often young people from key populations don't have money or don't have time to go too far, or early morning hours also do not meet availability and needs of these groups. Also, another very important facts about young key populations. Young key populations have different health needs. And this is crucial. Every time we are talking about young key populations, we should remember that there are different groups of young people there. Young men having sex with men, young transgender people, young people who use drugs, young people in detention. And young key populations may have coexisting vulnerabilities. Also, young key populations have poor access and uptake of services compared to older adults. So, talking about different health needs, let's have some examples. I will start with young people who sell sex. Here we are talking about those young people who are 18 plus years old. We know that in many cases, initiation into sex work takes place at an early age. And this initiation into selling sex in younger age leads to greater risk of physical and sexual violence, and may relate to a 2- to 4-fold increase in HIV infection. High number of sexual partners, more frequent unprotected sex, fewer skills for negotiation, condom use, and greater susceptibility to violence. HIV transmission among young people selling sex might also be increased in situation when young people selling sex at the same time inject drugs. Legal and policy unsafe and non-enabling environments increase risk of HIV infection. Young men who have sex with men, significantly higher STI and HIV incidence and prevalence, especially among young MSM of ethnic minorities, among young MSM and indigenous populations. Stigma and discrimination, perhaps the biggest obstacles. Here we are talking about bullying, harassment, family disapproval, social isolation, sexual violence, about high rates of emotional distress, shame, low self-esteem, anxiety, etc. Also, uptake of HIV testing services among young men who have sex with men is particularly low. Young transgender people. We have anecdotal evidence which suggests that there are an increasing number of young individuals coming out as transgender. Rates of HIV infection comparable to those of adult transgender females. We know that often young transgender people engage in sex work. Other associated risks: high-risk sexual behaviors, needle sharing and substance use, multiple sex partners, limited healthcare access and negative healthcare encounters, lack of knowledge regarding HIV infection and transmission, lack of condom negotiation skills, violence, stigma and discrimination, mental health issues. And young people who inject drugs. So we see that age of initiation of injecting appears to be decreasing. It's associated with accidental injury, self-harm, suicide, and unprotected sex. Also associated with high rates of HIV incidence. Because of several reasons: injecting or sexual partnerships, sharing of needles and equipment, and requiring help to inject. Also, many of those who inject drugs are those who also living and working on the streets. And of course, poor access to information, poor access to sterile injecting equipment, and poor access to HIV testing services. And here we are going to guidance of programs, of HIV prevention programs, or I even should say SRHR, including HIV prevention programs. So first of all, let me start with principles of programming with young key populations. So first of all, our programs should not be harmful to young people. We need to be ensured that programs designed that way that young people involved in this program are not exposed to harassment, abuse, or violence. So these programs should be human rights based. It should be gender sensitive and gender transformative. Talking about gender sensitive programs, the important thing here that they should provide services that take into account the needs of male, female, and transgender young people. And gender transformative principle is about ensuring that young people from key populations, individuals from key populations, have opportunity actively challenge gender norms, promote positions of social and political influence for women, and address power inequities between persons of different genders. Of course, it should be evidence-based, and here we should keep in mind that since, as I said before, we still have some gaps in the evidence. So first of all, we should include research component into our programs to cover these gaps in the evidence. And on the other hand, we should take data also from gray literature, from case studies, doing implementation research by ourselves. So all of this will help us to make programs evidence-based. Of course, it should be user-friendly. Here we are going back to one of my previous slides where I was talking about hours and location, for example, of services. Participatory, so young key populations should be actively involved by themselves in most of the activities of the programs. And these programs should affirm sexuality. So this is so important to ensure and to understand that these programs meet the highest available level of health and well-being in relation to sexuality, including the possibility of pleasurable, satisfying, and safe sexual experience. And moreover, we have evidence these days that if our programs promote positive sexuality, we see increasing of condom use of young people who've been covered by these programs. What are the important things in terms of international standards and guidance for implementing programs with young key populations? So let me divide it now into 4 groups. So the first one, laws and policies. So moving towards decriminalizing the behavior of young key populations, age of consent to services, recognition of transgender people in the law, access to justice and legal support for young people populations. Next big group of critical enablers, stigma and discrimination, anti-stigma, anti-discrimination and protective policies, provision of young population-friendly services, training and sensitization of service providers, community empowerment, programs led by young population organizations with meaningful participation. And one of the key components of our program focused on young K-popes and with young K-popes should prevent violence against young population and should support for persons experiencing violence. I hope you are familiar with implementing guidelines for provision HIV programs with key populations. We have several of them developed by key experts in key populations and endorsed by several UN agencies, and we call them MISNET for men having sex with men, transit for transgender people, etc. And we use the same approach for young key population as well. So I have this slide from the implementing tool for men having sex with men, and for adults and for young key populations, the main focus, the main center of all our programs is community empowerment. Because without community empowerment, we will not have any positive result of our interventions. Other crucial components around community empowerment: addressing violence, condom and lubricant programming, healthcare service delivery, using information and communication technology, including comprehensive sexuality education, especially out of school CSC, when we are talking about young population. Then we have international out of school CSC technical and programmatic guidance, which was developed with the leading role of UNFPA together with our partners, UNESCO, UNICEF, and UNAIDS and WHO. So go to our website and check it out. And of course, we are talking about program management. Quickly, what do we mean saying meaningful participation? And this slide is also from MISNET, from implementing tool for men having sex with men. This is about choosing how they are, in our case, young K-popes are represented and by whom, choose how they are engaged in the process, choose whether to participate, have an equal voice in how partnerships are managed. And I want to use the last minute of my time to show you this slide about lessons learned from the COVID pandemic. Of course, we have more, but these three I think most interesting. So first of all, of course, during the COVID pandemic, one of the positive effects of it was some kind of motivation for all of us, for organizations, to develop digital applications and platforms. But at the same time, we see that it's crucial to address the drivers of existing inequities, such as inequities in accessing digital platforms and technology. And in many countries during the pandemic, we found out that such traditional channels, mass media channels, as for example, radio or television, are still very effective to deliver information and messages to young people, including young key population. Also related to young K-popes, virtual outreach showed a lot of potential for engaging adolescents and young people from PPOPs. And once again, link with multi-component programs and services. We can't be effective in stopping HIV among young PPOPs if we only provide condoms, if we only do testings. Effectiveness of this program will be much, much higher if it's a comprehensive model of delivering different services to young population that could be health services and not only limited to SRHS services, legal support services, services to prevent gender-based violence, comprehensive sexuality education, etc., etc., etc. So I hope that within today's session, you will have time to discuss all of these aspects, to share your experience, and to decide what can be done differently. I'm jealous that I can enjoy in person or online, and good luck. I wish you to have a fruitful discussion.
So we had a very good overview there from Ilya Zhukov of UNFPA, and talking about some of the challenges faced by young key populations, some of the key principles that need to be applied to all of our work with young key populations, and then some of the enablers and the critical focus areas that people need to work on when assisting young key populations. Very challenging area, and lots of aspects that need to be thought about in young key population programming. And we're going to hear right now some experience from the field. We have Mary Mugambi from NASCOP in Kenya, who's going to talk about some of the practical approaches for implementing programs with young key populations. Mary, please, the floor is yours.
Thank you, Tim. I will be taking you, thank you for the introduction. I'll be taking you through our presentation for Kenya. And we are going to talk about programming with young key populations. So looking at the context for key populations in Kenya, Kenya has a mixed HIV epidemic. And we have different key populations. We include the female sex workers, men who have sex with men, and people who inject drugs. Also transgender people. So people in prisons and closed settings are also considered vulnerable populations. The key populations contribute to 33% of all new infections. Okay, I see some comments. Please confirm that you can hear me. Can you hear me?
It's breaking up a little bit, but you're coming through.
Can you hear me now?
Yes, that's good.
Okay, great. So Kenya has a mixed HIV epidemic, and I've talked about the various key populations, the female sex workers, men who have sex with men, and people who inject drugs, and transgender. Currently, we're also implementing for vulnerable populations. So the key populations contribute 33% of all new infections, and we have a high HIV prevalence. And for the high estimation of key populations, these are the populations down here, 197,096 for the female sex workers. We have about 51,100 men who have sex with men, 35,784 people who inject drugs, and about 4,370 transgender people. So sex work and drug use and same-sex relationships in this country are criminalized, just like many countries. I think move to the next slide. And basically these individuals live among the general population. So focus on young key populations. We have 42% of all new adult infections which occur among adolescents and young people, and that's between the age of 15 to 24 years. In 2015, Kenya developed the fast-track plan to end HIV and AIDS among adolescents and young people. And the transition study, which we conducted in 2015, also showed that adolescents and young people engage in casual sex, transactional sex, and sex works in locations where sex workers congregate but have very limited access to HIV prevention services. So NASCOP then conducted an outcome assessment among young key populations in 2017, and we found that their risk and vulnerability was high. So NASCOP also conducted key population size estimations in 2020 and found that about 10 to 12% of the key population locations are below 18 years, meaning the clients. So I think there is our fast track plan. You can move to the next slide. So based on this evidence, we had an intensive consultations with young key populations, and in 2018, the National Key Population Program developed the National Implementation Guidelines for Sexually Transmitted Infections and HIV Programming among young people populations. And the proposed comprehensive package of intervention was based on global and national guidelines and recommendation from the adoption of the combination approach for implementation. And there in red and yellow is our young key populations guidelines. Next. So we had the pilot project. As NASCOP, we piloted interventions with young men and women who sell sex and young men who have sex with men. And we had the various partners, Jhie, Partners for Health and Prevention, Mamboleo, which was our MPEG organization, and ICRH. This was between 2019 to 2020. This evaluation here shows that the interventions with young people populations are possible and effective. You can see the numbers here, those who had ever taken an HIV test and those who had an HIV test in the last 3 months. We also down here on the graph, you can see the ART uptake among MSMs then. So in the chart there, you can see the registration that kept going up for those who are below 19 years. And also the total registration. Next slide. So what are our scale-up plans? We've consolidated the evidence from research and assessment for the pilot programs, and we have documented on the same. You'll be seeing a video of that. And then we have had advocacy with key populations and community networks, the county governments, the stakeholders, implementers, and also the technical working group. We've also have plans to monitor the key populations program. This is disaggregated by age, and we've been able to make those changes on our data systems. And then the learning and evidence has been included in the country global fund proposal for scale up in the different geographies and different young subpopulations. So the following film documents our pilot project involving young women who sell sex and young men who have sex with men. And the learnings are now being replicated in other geographies to cover all other young people populations. I hope you enjoy the video. Thank you.
Kenya is a country of great diversity. Straddling the equator, it is home to the Big Five and cultivates some of the world's richest coffee and tea strands. With the savanna within its borders and the Indian Ocean off the coast of Mombasa, the Kenyan landscape is a cataclysm of contrasting beauty. Home to 50 million people, it is against this background that one of the largest HIV epidemics in the world exists. According to UNAIDS data, 42% of new HIV infections occur among adolescents and young people. Part of these are young key populations, and they represent the proportion that is at a higher risk of contracting HIV and include young men who have sex with men, young women who sell sex, young people who inject drugs, young transgender people, and young people in prisons. Even as young key population are recognized as a vulnerable group, the global response to HIV has largely sidelined young people. To address this, Kenya has developed the Fast-Track Plan and the National Implementation Guidelines for HIV and STI programming among young key population. A pilot intervention was initiated with young men who have sex with men and young women who sell sex in Kiambu and Mombasa respectively. We partnered with MPEG, a KP-led organization in Kiambu, and ICRH Kenya, an NGO which works in Mombasa.
Kwa majina naitwa Margaret Wamboka, nimetoka mtaa Bombolulu. Napenda sherehe, napenda sheshe, kutoka nje na mabeshte, kuchonga, kukunywa. Yaani hivyo ndio mimi tu anapenda. Kuna siku ilikuwa naenda tu kibarua tu hivi kama kawaida, nikakutana na Pia. Sasa huyo Pia akanielezea, akaniita, mambo poa dada, kuna services tunafanya pale DIC kama unataka family planning. Alafu nikikumbuka ndio nimetoka kuzaa, alafu sijui mambo na family planning. Akanielezea kuna miezi 3, kuna miaka 5, kuna zile pills. Alivyonielezea, alafu akaniambia kuna tembe zinaitwa PrEP. Alivyoniambia hivyo, nikafikiria, nikamfuata paka huko DIC. Nilipofika nikapatiwa service, nikaelezea, nikapatiwa cancel.
Young key populations not only experience higher risk of acquiring HIV, but are also vulnerable due to a myriad of social and structural factors. For example, while unprotected sex is a significant risk factor, there is evidence that young key population are often more vulnerable to effects of poverty, discrimination, harassment, violence, social isolation, criminalization, and self-stigmatization. In addition to addressing multiple overlapping risks, programs with young key population are working towards developing supportive policies, providing stigma-free services, improving access to scholarship for education and skills training, violence-related support, among many others.
Nilivyomaliza hizo service, sasa nikakuja na mimi pia nikaelezea wenzangu. Pia wenzangu nikiwapeleka wanatumia hizo PrEP, hizo service za family planning. Sasa pia huko kwa hotspots, kwa sababu pia mimi nabangaiza. Sasa zile service zilinisaidia DC, nikaambia na wenzangu sex worker wadogo, nikawaelezea kuhusu hizo service, na wapeleka pia nao wanaambia wengine wanaenda.
There are a host of reasons why young people, particularly adolescents and young girls, sell sex. Poverty, gender inequality, and limited access to education are just the tip of the iceberg. Yet even while Transitions research from Mombasa indicates that 52% of women who sell sex in sex work locations are below 24 years, they remain underrepresented in research and HIV prevention programs.
I came to know MPEG at around 2017 after high school. You know, this was the time when I was so naive. I didn't know things about how I can prevent myself from HIV or from STIs, or where I can get services. So I came across a friend who was actually working in this DIC, and he introduced me here. At first I was hesitant because I thought maybe, I don't know these people, what are they going to do to me? But after some time, when I got here, the reception was very welcoming. So I registered my names, went to the doctor, had a conversation with the doctor, and I got enrolled.
So there was need to bring those hard to reach people, youngsters that are online, are all over online, and they don't want to come to seek services. Youngsters want to be reached by youngsters. I want mtu tunaongea na yeye ana resonate na mimi, tuko almost the same age. Alafu si kukwambia tu, don't just tell me about coming for HIV. You see, that is what have led a lot of sites not even have young people, because our sites have become like hospitals. There's nowhere you'll find youngsters chilling together, playing PS, watching a movie together, doing makeup. You see, having a movie night, kukula popcorns pamoja. There is no that, because our sites have become hospitals. Unasikia tu madawa, unasikia tu watu wagonjwa. So there was that gap to change, to make it more friendly, to attract more people, more youth to come to the center. And you will find them. You will not find them in the streets. You'll find them on social media. We have social sites, we have groups, and all those social network and sexual networks. Those are two places that you'll find a lot of youth.
The way they welcomed me to the doctor, I was already comfortable with their services, and once I got to the doctor, he introduced me to the organization. He told me what they do. They offer HIV prevention services, they give STI services. In case you have any diseases, you can come here and get any service for free. This was something that was really exciting, because I was used to going to like public hospitals, and when you go usually to public hospitals, most of the time they won't make you feel home. So the kind of reception that was here made me feel good, and I think we had a connection, and I came and started receiving services from the DICE.
Data on young men who have sex with men is scarce. However, emerging numbers point to them having heightened risk and vulnerability. There are a few programs specifically tailored to their needs, which limit their access to sexual health education and services. They also face criminalization and the stigma attached to same-sex relationships. As a group, they are at increased risk of abandonment and violence from their families.
We normally offer services to the young KP, that is the biomedical intervention, structural and behavioral. We also do the psychological support to them, because most of them are actually going a lot of mental health challenges. And most of them, they find these places a bit safe for them to come and share with us. So we do offer the services to them still.
The country has developed guidelines to inform national programming for HIV and STIs among Yankee populations. The guidelines emphasize the need to involve the Yankee population at all levels of program and policy design, implementation, and evaluation, so they can own the program.
Yeah. Mimi hadi nikiwa tawa, I can just peep in, kukaa kiasi, relax, wifi deals ni kwa manga. Hiyo pia inasaidia, uko na place penye hautaenda ukae ulizwe ni nini unakuja kufanya. Yeah.
Una feel at home, you can do anything you want. Like no one is there, no one is judging you. Unakuja kani lunchtime, maybe you're working, na kama una chill. Kama leo. Venye tulikam, unapata kuna wase wengine hapo, at least unaweza ongeleshea. Sisi tutakam, unapata mabeshti, you can make friends.
Watu wa form wanakuja kufikia form. It's just fun hanging out with friends and for your well-being.
Children and adolescents below the age of 18 are exceedingly vulnerable to sexual exploitation. They have a greater inability to negotiate safe sex, access sexual and reproductive health services, and exist under the constant fear of harassment and exploitation. This drives them away from programs and services, making them invincible. Yet young KPs are protected under several laws, including the United Nations Convention on the Rights of the Child, UNCRC, the African Charter of the Rights of the Child, ACRWC, the Constitution of Kenya, and the Children's Act of 2001. These provide for the survival, development, protection, and participation rights of YKPs.
The challenges we face in programming for young KP are many, and some of the issues we find is during our outreaches and being in places where sex work is happening, we find young girls and boys under 18 who are selling sex. Since they're already in those areas, we provide services for them. And so we'll give them services like sexually transmitted infection screening for them, HIV testing for them, provide treatment. But before that, the most important is linking them to child services.
Young key population need to be effectively included in the HIV response. To do this, an understanding and recognition of the emerging needs of this group is required.
The policy guidelines have in various ways contributed to addressing the needs of YKP. The first thing is that the policy guidelines give practitioners and programs some level of confidence to approach KP or YKP service delivery. So one of the things you find or you know is that it's quite controversial providing sexual reproductive health services to young people, and many clinicians are often reluctant to provide sexual reproductive health services to young people. But one of the things the guidelines have done is that they now health service providers and programs are aware that there are policies and that there are guidelines and that they are operating within a legal framework, and that gives them a lot more confidence to provide services to most or to many of these people.
For the government of Kenya and the counties, it has been that challenge of ensuring we meet the prevention need as we work towards abiding by law and working towards behavior change. And so to facilitate this, we set up county key populations TWGs, whose role, apart from the general key population, has been to address emerging concerns and trends around key population program and prevention needs. And so this has become a concern in all KP TWGs, and that has given a platform for engagement with the stakeholders who have a responsibility over young people who are KP in their lifestyles, bringing together education, security, judiciary, and that has given the structural environment for provision of prevention services.
While programming for young key populations is still in the early stages, it is essential to anchor the provision of services to select key principles. These include ensuring that young key populations have their voices heard, minimizing harm to them, not discriminating on any grounds, and remaining aware of their vulnerability. To achieve maximum benefit, collaboration with families, community leaders, county bodies, and different sectors will be essential. Young key populations have needs beyond HIV and health, and hence the program would have to ensure that all these needs are met in partnership with other organizations.
There was really a gap to really reach out to the young KP because they have needs that cannot be reached in the mature program, because these are young people, and for young people they need a lot of sexual and reproductive health services. They need a lot of integration of youth services and youth-friendly services. For the general KP, it's just ensuring that, of course, we reach them with specific services, but services that are KP-friendly. But for this one, apart from KP-friendly, it also has to be youth-friendly.
We need to create an environment whereby young key populations can actually share. That is ensuring that there is safe spaces, be it at drop-in centers, be it just, at homes, because young key populations are part and parcel of the community, and since they are our leaders of tomorrow, we need to ensure that they are equipped with education, and this only happens at safer spaces.
Sasa mimi nina miaka 22 na niliingia DIC nikiwa na miaka 17. Nashukuru imenisaidia kwa sababu ilikuwa sijui mambo na family planning, wakanisaidia. Hasa nashukuru DIC kwa kunielimisha.
If you'd like to learn more about Kenya's programming for young key population, send an email to NASCOP through their website www.nascop.or.ke.
Thank you, Mary. That was a wonderful presentation and film showing your services there. Are you wrapping up now?
Yes, Tim. I think we've wrapped up. Thank you.
Thank you. Yeah, we're about at time. Okay, so we saw there some wonderful actual services, putting some of those principles into practice that Ilya was talking about, to have youth-friendly services, to have a hybrid model with a drop-in centre, peer educators, as well as virtual programming, and a youth-friendly, key population-friendly clinical service. So you have to have all of these components coming together into a trusted access platform which young key populations feel comfortable and able to come without any stigma and discrimination. Thank you very much, Mary. Now we're going to hear from some young key population members themselves. And first of all, we've got Ralph Ivan Samson from the Philippines. Ralph, please, the floor is yours. You've got about
Thank you so much.
You've got about 8 and 9 minutes.
Yeah, thank you so much, Dean. I hope I can share my slides. Okay. Okay, just wanted to confirm if my slides is okay now.
Yes, we see them now.
Yeah, thank you so much, Tim, and the rest of the organizers for inviting us here, particularly coming from youth organization, and for sharing your safe spaces with us. So for this afternoon, allow me to share with you our work in YPR Philippines, entitled What Young People Can Do, Unleash Ourselves. So again, I am Ralph Ivan Samson. I'll be turning off my camera because I'm actually in the humanitarian response right now, and the internet is quite challenging for me. So as you know, adolescent and young people always feel invincible, and I guess majority of us here are experience or already what we call this one, experience growing up as a young people, and we feel that sometimes we are so powerful. However, there are so many challenges in the ground or even in our community that prohibits us or hinder us to grow. So in the age of social media, many adolescents and young people are actually using social media to interact with each other. And these trending topics are actually the most common trending topics. I guess here in the Philippines, I can share with you, here in the Philippines, these are the most famous hashtags among adolescent and young people populations, which includes, you know, chemsex, alter, with the age of TikTok challenges, relationship goal, as they will be able to find their attractions to same or opposite with their gender identities, and the rise of different online games. However, there are so many challenges of young people that is being experienced among us that we don't able to manage to discuss among ourselves. I'm sorry for the background. These are the challenges that many young people and adolescents are experiencing but not able to discuss among ourselves, primarily with all the challenges and barriers that were mentioned by the first speaker and the second speaker a while ago. This includes teenage pregnancy, HIV and AIDS, the rise of mental health, the bullying, the body image disturbance, and all among other issues of young people. And basically all these issues are actually boils down to lack of youth participation. So many other countries really quite challenged for young people to participate, particularly in the decision making. Also, I would like to put emphasis that those issues that were presented are actually pre-COVID issues already. However, with the rise of COVID, we have seen a lot of lockdowns, which adolescents and young populations are the primary target of this very discriminating policies of the government. Many young people are prohibited to go out basically because of the COVID-19. And these restrictions put in place preventing adolescents from seeing their friends, the socialization, participating in usual activities, which many young adolescents needs in order to develop their social skills. And many of our adolescents also experience challenges, particularly those adolescent and young populations who are living with HIV, who are living in a violent environment at home, wherein schools and friends are considered as their safe spaces. But during COVID, these issues have been quite challenging for many adolescent and young population. Apart from COVID, HIV in the Philippines, as you know, Philippines is the most fast track, I mean, like the most high cases of HIV around the world. But I would like also to share with you that these numbers has a good implications, which we will be sharing with you later on. So again, not just in Asia Pacific, but Philippines is one of the highest HIV prevalence in the entire world, primarily because of so many challenges that I already mentioned. But later on, I will be sharing with you the reason behind also the other side of the coin. And of course, as you know, the Philippines as a part of the in the Pacific, we don't experience not just COVID, not just experiencing about HIV, but we also experience natural calamity and natural disaster brought by climate change, brought by so many natural disaster, volcanic eruption, typhoons, etc. In fact, in this last year alone, we experienced the most strong typhoon, the Typhoon Rai, that up until now, we are responding here under the United Nations Central Emergency Response Fund here in the Philippines with UNFPA. So the lack of SRH information due to stigma discrimination, it will actually leads to increased risk of sexual exploitation and abuse, or the SEA. And this also put adolescents high at risk of unwanted pregnancies, unsafe abortion, and STI and HIV infections. And with the existing COVID-19, it actually complicates the delivery of needed humanitarian response in typhoon hit areas, particularly in Samar, in Southern Leyte, and other regions facing in the Pacific area. So framing of support, as we work with UNFPA, we have actually the same framework of support, my body, my life, and my world. It's one of the global strategy in engaging young people and adolescents, primarily ensuring that they have integrated access to SRH information, addressing determinants of health and well-being, and primarily promoting participation and leadership. So we were able to develop this adolescent sexual and reproductive health in emergencies, wherein the main goal is to ensure the continuity of life-saving information and services for adolescent and young people, even during disaster, and making sure that no one is left behind. So in partnership with other youth networks, the PYDN, the UNSDS and Youth in the Philippines, the Love Yourself, with initial support from YPR Asia Pacific, Youth Lead, Plan International, we were able to launch the online COVID-19 response on ASRH, or in local term, we call it Kabayanihan. And Kabayanihan is actually a two words of Kabataan and Bayanihan, which actually literally means uniting with each other. Bringing our innate potentials to work together as young people in our community, working collectively to achieve a common goal. So as of since the COVID-19, we were able to launch this Quarantox with more that were able to reach 95,426 all over the social media platform, and able to engage 37,223 total engagements. With 11 online episodes and 17 infographics developed with 23,426 total reach. And we also launched the online COVID-19 response, the first ever online training that we developed from face-to-face that we used to conduct pre-pandemic. We were able to transform our peer education into online platform, and we developed this on YPeer University. As of to date, the first batch were able to receive 154 applicants. However, with internet connections here in the Philippines, there are only 17 who finished and graduated the first ever online training course on ASRH in emergencies. And we're trying to develop into other platforms in the upcoming years to come. And also, we were able also to develop this online peer education training that are being used by different organizations with support also with UNFPA and Zwilig Foundation. And it was being implemented in 9 municipalities across the Bangsamoro Autonomous Region in Muslim Mindanao and in Region 12 as well. well, in partnership with UNICEF, with the Council for the Welfare of Children, the National Youth Commission, and with other networks, the PYDN, we were able to develop this guideline for safe adolescent and youth engagement in online platform while community quarantine, particularly to address online sexual exploitation and commercial sexual exploitations over the online. And we are very much happy because we have government representative here who can actually share also their experience, why there's a need to work with adolescents. And we are very much thankful that we were able to identify champions from the government who also advocates for youth participation. And the most famous thing is we were able to launch the hashtag #GetCondomPH, wherein during community lockdowns, we were able to develop these quarantines that all condoms together with the antiretroviral drugs were being sent to different key populations in order to ensure that they have access to condoms and lubricant even during community quarantines. We were able to hire like the Grab, if you're familiar with the Uber version, but here in the Philippines we call it Grab and other riders, in order to provide these commodities even during community quarantines, particularly for those ARV refills for young adolescents living with HIV. And initially we implemented this one in the capital, but we were able to scale it up in different parts of the country. And to scale up Kabayanihan, we are very much happy with UNFPA because the Kabayanihan was able to scale up into a more intergenerational dialogue, engaging young people and key government officials primarily to address COVID-19 and given a chance adolescents to ask questions to our government officials, primarily from the Department of Health about the COVID response, from the Commission on Human Rights and the Department of Education. So we were able to invite secretaries, commissioners, undersecretaries in key government offices in order to provide updates with young people and being led by young people ourselves. And we were able to reach the 786,536 all over the media platform.
If you can start to wrap up now, Ralph, please.
Yeah, and of course, we know that we have this seed grant also, the Kabayanihan Challenge Fund, also the typhoon response, about the emergency tin kits that we were able to distribute all over the countries, and making sure that adolescent and young populations have emergency tin kits during emergencies, that is being supported by the UNFPA. And with the Kabayanihan Challenge Fund, it's actually a seed grant given to community-based organizations in order to develop programs that necessarily address their needs in the community. And with the lastly, our humanitarian response for Typhoon Rai, we also spearhead the peer education training and mobilizations of young people to conduct school and community-based peer session as we transition to normalcy with the COVID-19 face-to-face with the Department of Health, the cash for education, cash voucher assistance for adolescent and young girls. And also YPeer as a youth-led organization, we co-lead the activations of our reproductive health coordinating team for MISP on SRH subclusters and able to conduct also the reproductive health medical mission. It's quite challenging, but again, if young people are given chance to lead, we can do so much. And these are all our interventions. Share with you our success. And right now, there are so many LGUs who are also trying to procure or adapt our emergency tin kits in order for them to provide them to their local adolescent and young populations. So again, we go on the saying that nothing about us without us, but most importantly, on the saying about we know the market, and we are trying to target the market because we are the market. So again, thank you so much for this opportunity, and we are looking forward also to other partners to join with us, and I hope we inspired a lot of youth organizations who are here to continue to engage our government and civil society organizations, particularly with the United Nations agencies. Thank you so much, and mabuhay.
Thanks so much, Ralph. What a wonderful program that you're leading. The young people are leading themselves. It really shows a great example of what young people can do if they're given some resources and support, and how they organize things, because you know what you need. So it really is excellent. Let's go straight to Fatma now in South Sudan, who will give us another perspective for young key populations. Fatma, over to you.
Okay. All right. Thank you so much. Good afternoon, good morning, good evening to everyone. My name is Fatma Iddi. I'm a young key population from South Sudan. I am the national coordinator of the Key Population Network in South Sudan, and I also double as a role of co-regional coordinator for the East African Sex Workers Alliance. And I serve as a board member for the Network of Aid Service Organization in South Sudan, representing the key population. In my presentation, I will talk about what we have done or what we are doing in South Sudan, or what has been done, and then some of our challenges and the way forward, what we would wish to be done for us as key population in South Sudan, in Africa, East Africa, and globally. The key population programming in South Sudan is supported by PEPFAR and Global Fund, and the population is estimated at around 13,000 as a program size estimate. The package of services that key population members or community receive include the HIV testing services, family planning, STI screening and treatment, GBV screening and support, condom promotion and distribution, psychosocial support, and among others. The program has identified and trained peer educators and navigators as peer outreach workers to help reach female sex workers, who are the most considered key population group in South Sudan, with different services and community level support. Through support and engagement of the peer educators and navigators, around 3,000 female sex workers are being identified and active on ARTs in South Sudan. The coordination and collaboration with the Ministry of Health, South Sudan AIDS Commission, UNAIDS, Network of AIDS Service Organizations, advocacy on key population have been held to the high leadership as part of enabling environment creation for key population service provision. The support from UNFPA for condoms and lubricants is enormous and has met the needs of the female sex workers and other key population groups for condoms and lubricants in the country. As we all know, the epidemic continues to disproportionately affect key population and their sex partners, and they are the people who are acquiring HIV in big numbers every day. And this is part because of the discrimination, criminalization, harassment, and social exclusion that the key population experience every day in their day-to-day work or in their day-to-day lives. If we want to achieve the 95, 95, 95 HIV global targets, we should not leave anyone behind, and especially the young key population. And when I'm speaking about the young key population, I'm speaking of the sex workers, gay, LGBTI community that are between the age of 10 to 19. We all know that the key population below this age of 18, they exist, but because governments and donors do not want to work with them or do not want to talk about them because of funding restrictions and other reasons, the number of new infections in this age group, which has been neglected because of their age, keep increasing every day. This is because of lack of knowledge in them and empowerment, and also fear of getting services from facilities, because they are always asked to come with parents or guardians, or they must have consent from their parents or from their guardians. We urge that governments should design programs or linkages to child programs that are specific to the needs of the young key population because of the stigma, discrimination attached to the general services that are provided in the normal setting of service provision. The international resources from bilateral and multilateral donors allocated to key populations and human rights interventions are already scarce. So, if the implementation of key population programs are still done by international partners or international organizations, this means reaching key population with services will still be a problem due to trust issues and lack of knowledge of the actual situation in the grassroots or in the communities by the international organizations. So these are some of the challenges that we are facing. Leaving behind the young key population, donors and governments not being able to give the actual funding to the key population-led organizations for them to be able to implement their own programs, because they are the people who knows what their needs are, they know what needs to be done, and they can be able to reach even the most hidden population that do not want to come out to receive services. So we are asking for this to be done. Would like the governments or the donor world to be able to, like, building of cross-sector alliance shared between the key population, which is engaging in the HIV response, and intermediaries could help in bridging the conceptual gaps, and it will also help in increasing the limited capacities that key population communities experience when trying to engage in decision-making processes. We advocate for the inclusion of young key population in designing, planning, and implementation of HIV programs meant for key population, so that we are able to, so that we do not leave anyone behind, and through this we'll be able to achieve the global targets. We also urge the governments to fulfill their human rights obligations by repealing the discriminatory regulations and take steps to have transparency and social accountability mechanisms in place where key populations can be able to participate. We also encourage the donor world to advance funds to key population-led organizations for appropriate utilization on activity implementation, with key focus on target and reach of the intended beneficiaries with the services. I would say this: we as the key population community, we are tired of baking the cake and not be able to eat the cake when the time for eating the cake is there. By this, I mean, when HIV programs are being designed, planned, and we are always involved through consultations. We'll be consulted, we'll be involved in the planning process, but when it comes to the actual implementation time, we are left out. With this, we submit our priorities, we submit our budgets, but when the time for implementation comes, we are told we have no capacity. Why are we not supported to build our capacities as key population-led organizations to be able to implement our own programs? This is a question I'll throw back to the governments and the donors. Why are we not supported to build our capacities? If that is the reason why we are not being able to be given our own funding, to be able to do our own implementation to reach the intended beneficiaries with the services. We have done research in South Sudan on young key population, and especially from the ages of 10 to 19. We have a growing number of key population, and especially sex work. We have young people from that age of 10 to 19 who are joining sex work. Through this research, we came to find out that there are so many reasons that are making them join this business. One, it's because of poverty, because of discrimination from family, just because their parents have been in the sex work, and other reasons. But we still have some of these groups who would like to go back to school. Some of them joined because their parents could not be able to push them back to school. But they do not have support to go back to school. So I would urge.
You can start to wrap up
yes,
now, Fatma.
Yes,
yeah, thank you.
I would urge UNICEF as an organization that works with children, if they can be able to do a research on this and be able to help for the population that would like to go back to school or have skills development for this, it should be taken up. Then finally, I would say there is nothing for us without us. If our programs are designed, planned, implemented, and monitored on our behalf, we'll not be able to reach our targets. So if it is for us, it should be designed by us, planned, implemented, and monitored by us as key population. Let's leave no one behind. Thank you so much.
Thank you very much, Fatma, for another really interesting presentation and a very challenging situation, and how young people have really taken the lead in these programs and can really make a difference. Thank you very much. We're running behind time, so I'm going to go straight to the panel now. And our first panel member is from the NAC of the Philippines, Normina Mojica, or Jhie. I'd like to invite you to make a few remarks. Jhie, please. Are you there, Jhie?
Sorry. Can you hear me now?
We hear you. Thank you.
Oh,
there's quite a lot of some background noise.
Huwag mo na daw kayo maingay. Kasi habang sasalita na ako, there's a lot of background noise daw. Wait lang. Huwag ka magulong puti ka, ha? Papaluin kita. Okay. Okay. I hope you don't hear any more background noise, not so much of the background noise. Am I on mute?
Please go ahead, we'll try, we'll see. Now you're muted. Jhie, you're muted. I think in the interest of time, sorry, we might go, Jhie, we're going to go to Wade now and come back to you later.
Okay, Tim, I think that would be better.
Yeah, okay. So we have Wade Ivy of the CDC. Please come in, Wade.
Thank you, and good morning, good afternoon, everyone. It is a pleasure to be here to discuss programming for young key populations. I am Wade Ivy, a member of the Key Populations team at CDC headquarters in Atlanta, Georgia. And we all know that members of key populations face risks of HIV acquisition that are many times higher than the general population, and young key populations are often at even greater risk of HIV transmission due to additional barriers and risks they encounter that have been detailed very nicely in the presentations already today. HIV programming for young key populations within PEPFAR aims to address these specific barriers through a collection of client-centered, differentiated HIV services. The latest Country Operational Plan, or COP guidance for fiscal year 2023, provides the framework and details for PEPFAR programming priorities for young key populations. Many operating units reach young people in their KP and other relevant programmatic activities like DREAMS. However, specific young KP interventions are quite nascent, and more operational approaches that are tailored to address the specific needs of young KP and the structural drivers of infection are critical for PEPFAR prioritization and scale up. Differentiated models are extremely important for young KP programming, which allow for more client-centered approaches. We know that young KP are more likely to be reached through outreach activities, especially when utilizing young peer workers, and it is especially important these efforts are led by KP competent and youth-friendly organizations. In addition, we've seen that programming is most impactful when it's comprehensive in nature. For example, providing comprehensive HIV and sexual and reproductive health services, including STI and voluntary family planning, ensuring that violence prevention and response, mental health and psychosocial support are prioritized, providing services in one place and limiting the need for multiple referrals and interactions with various staff, linking to or providing social protections and socioeconomic empowerment services, and utilizing virtual and online approaches to reach and support young KP have all been shown to be essential to improving services for young KP. As PEPFAR continues to enhance its approach to serving marginalized young KP, it's essential to engage this population with a respectful, supportive, and confidential manner during all phases of programming from planning to implementation. With PEPFAR's focus on client-centered approaches and specific attention paid to the needs of young KP in the COP22 guidance, we are supporting countries to think about and produce more integrated, impactful, and responsive programming for and facilitate better engagement with young key populations. So thank you for the time, and I'm happy to answer any questions after.
Thank you, Wade, for a very comprehensive, holistic view of what services we need to put together for working with young key populations and being so concise. I'm going to go straight now to Ed Noskin of the Global Fund. I think many of you know Ed, and we'll get the perspective of the Global Fund. Please, Ed.
Thank you so much, Tim. I'll just turn on my camera shortly, but recognizing the connection issues, I think I'll just turn it off as I share my reflections. So thank you everyone for allowing me to share reflections from the Global Fund. And first of all, I just want to acknowledge that overall we are far behind in terms of providing funding for programs for key population more generally. Even though there's some slight increase in the proportion of funding to key population program within the overall HIV allocation that we made available for countries, the pace is too slow. And as we are preparing for the next funding cycle, we are finding ways to be much more strategic in guiding countries to better prioritize HIV prevention, testing, treatment, and care and support for key populations. And this includes also working with partners, many of whom are presented here, to better measure prevention outcomes in our program. Secondly, we are fully committed to addressing specific needs of adolescents and young key populations. We have asked and continue to ask that programs recognize and address these additional vulnerabilities, which is already highlighted by our colleague Ilya from UNFPA earlier. We ask that the key population and youth programs work together hand in hand to provide age-appropriate services and create multiple entry points for HIV services to take into account those overlapping vulnerabilities. And this includes any individual harms associated with sexualized drug use, mental health, homelessness, down to criminalizations. And most importantly, to do no harm when it comes to engaging and delivering services to and reporting on adolescents' key populations. These are explicitly mentioned in our grant guidance, and we continue to highlight them as we enter into another round of funding. In fact, improving sexual health and well-being, along with making HIV-related services accessible in multiple platforms to promote options that young people can choose, is extremely important. And this is the directions that the new strategy is asking us to do more and do better, learning from how we have supported countries in the current and the past allocation period. And a great example you have seen and heard today from Mary, which is our partnership with NASCOP to support scaling up a program for these particular communities. And finally, scaling up our programs for young key populations can only be achieved when we ensure meaningful engagement and decision-making. We need to also continue to invest in comprehensive program to address human rights and gender-related barriers to services. The only way we can do this is through enabling access to funding and technical support for youth-led and KP-led organizations, something at the Community Rights and Gender Department, which is the department I work on, have been doing, and we continue to do our best to make sure such support continue to be made available. So thank you so much for your attention, and for the speakers today who shared brilliant insights and lessons learned on this very important topic. Thank you very much, and back to you, Tim.
Thanks so much, Ed, for a very succinct overview of the Global Fund's approach and focus. And yes, I'd like to reiterate that it's essential that for this next round of grant making that we do focus on trying to get as many key population and young key population sub-recipients and projects funded through the Global Fund in many countries. We're going to go now to another key population perspective. I'll call on Aditia Taslim to give you a few remarks. We're very running out of time, I'm afraid, but if you could just give some brief remarks, Aditia.
Sure, Tim, thank you so much, and thank you for inviting me to this webinar. And hi, everyone. I'm very glad to be here. I'm Aditia, based in Indonesia. I'm with the International Network of People Who Use Drugs. Just a few things that I picked up from the discussion today. Also wanted to highlight that we need to be careful when we address issues around behaviors of key population. I think somebody asked that in the Q&A section just after the first presentation. Because, I mean, for us, for key population, I mean, we are getting blamed a lot, right? I mean, for the whole of our lives, and that it's very easy. And when we focus on behavior, it's very easy for others to really point their fingers on us, and especially and unfortunately when we don't live in an ideal world. And while some countries are progressing towards fulfilling the needs and rights of key population, but others, and most of others, there aren't. The rise of conservatisms, and we see a lot of countries are actually pushing back against particular key population groups, and that we need to bear in mind when the associated risks, whether it's sexual behavior, whether it's drug use, they're highly driven by many other things: inequalities, socio-economic disparities, as well as structural barriers. And we need to remember that out of 194 countries, there are still 39 countries that haven't adopted same-sex non-criminalization. There are still 150 countries that criminalize sex work. There are still 169 countries that criminalize drug use and possession. And there are still 111 countries that impose age restrictions to access services. And we are here almost midway, 2022. That means what we have 3.5 years to go to 2025. Then we need to remember that we have that target. Less than 10% countries criminalize same-sex sex work, drug use, and age restrictions, including also HIV transmissions. And also, I think, and even after 40 years of responding to the epidemic, I think we still continue to fail to recognize and to understand the complexities of needs of the different key populations, including young people. I mean, how often do we see countries not having sufficient data on key populations, especially that most of the data are not aggregated by age? And this is very critical, because this then will lead to many things. Like scale up would be very much impossible. I mean, in reality, we don't see scale up on harm reduction services, but we see service closures because the number is too low, or that there's no sufficient data to support that. And it is an important point that raised about commitment to invest in key populations, especially younger organizations, smaller organizations led by young key populations, led by populations that are criminalized, like people who use drugs. But we also need to remember that many of these organizations in many countries face criminalizations, that they also face barriers to be formally registered as organization, thus even limit further their ability to access funding. And we need to really ask ourselves and to just sit together with all the donors and people involved in the response, whether it's global, regional, and national level, to really look at what do we mean by engaging and meaningfully engaging and involving key populations, especially young key populations. So yeah, I don't want to come back in 2025 talking about the same issue again. I think this is really the opportunity that we have. We have good targets, we have strong targets. It's really a matter of, how do we put that into action? And yeah. Thank you.
Thanks a lot, Aditia. You really hit the nail on the head, I think, there, with the challenges faced and the increasing conservatism and the lack of space for key population organizations to function and to grow, and the lack of resources. So these are real challenges that we have to continue to really face and think of constructive solutions. We're just going to try to go back to Jhie one more time. We are getting over time now, so but I'll give Jhie the floor one more time for a few remarks.
Thanks, Tim. Can you hear me now?
Yes, we can.
Okay. And I have lessened also the background for that. Well, thank you for inviting the Philippines to share what the government is actually doing. If you would allow me to share screen, I just had 2 slides that would more or less encapsulate what I would be saying. Would it be okay?
Please, yeah. Please, let's get them up as quick as we can.
The Philippines has always advocated for, if I can turn off my camera now, the Philippines has always advocated for children's participation in all the issues that children are actually concerned. We have increased efforts in raising awareness on teenage pregnancy, HIV and AIDS, and other sexually transmitted disease. And like Ralph was saying, we have conducted webinars also on adolescent sexual reproductive health, and even have advocacy films wherein the adolescents would actually really find out what they should really be doing in terms of when they're confronted with problems like teenage pregnancy and something on HIV and AIDS. And we have also maximized the mandate of government agencies to respond and incorporate the issues of children and adolescents on their programs and interventions, and also to strengthen their interagency coordination. How do we do that? We have certain structures, especially with the Council for the Welfare of Children, who is the focal interagency government body in the Philippines that focuses on children. We have, of course, at the top level, the council board, wherein we have different ministries, or what we call the line agencies here in the Philippines, and coordinating body on children's concerns, where a young person really sits as a member of that council board, and a structure which is focused on children and HIV and AIDS that serves as the sounding board of the highest policy coordinating body on concerns on HIV AIDS, where a child and youth representative is also a member. And Ralph mentioned about how we're also, because the Philippines is a disaster-prone area, so we have the National Child Protection Working Group that actually sees also into the humanitarian response, and that also considers where children can actually be subjected to sexual abuse and exploitation. Now, we were able to really maximize the government agencies responding on the issues of children and adolescents, especially when we worked on the protocol and the provision of proxy consent for HIV testing services of children vulnerable to and at risk of HIV. The old law does not allow children to have testing service, HIV testing services, or access to reproductive health commodities. But now, with the new law, and given the consultations we had with children, and also trying to desensitize adults and desensitize the stakeholders on why children should be involved in such a very taboo or very delicate issues, then we were able to incorporate in the new HIV and AIDS Policy Act the inclusion of 15 years old for HIV testing. The legal age for HIV testing is now 15 years, and that don't require parental consent anymore. And what requires parental consent, and wherein a social worker or a medical doctor can come in to give that proxy consent, is anyone below 15. And during the pandemic, there was also a joint memorandum circular for several agencies, one from the Council for the Welfare of Children, and also from our Department of the Interior and local government, which actually handles issues on local government units. So this actually gave the ways on how we would be able to handle children during the pandemic. And of course, there's also the health, nutrition, and child protection referral pathway for the COVID-19 emergency. The next one is we keep on strengthening the capacity of duty bearers to respond to the issues of children and adolescents. Strengthening the capacity of duty bearers and community members would also include youth organization that enables community members to value and further engage children and adolescents. That was highlighted in Ralph's presentation, so I won't delve on that anymore. And to ensure the participation of the children and adolescents in crafting plans and strategies, we have enhanced the guidebook on child participation to ensure that children are really in every part of governance, even the development of the policies, they are involved. So the children are no longer seen as beneficiaries of certain services or our clients, but they should be really viewed as agents of change and be allowed to participate in policy formulation and implementation. These we would share to you in future or even through Tim or the organizers, our Young Heroes initiative, wherein young people really came up with programs or advocacy activities that could help in this issue. That would be all, Tim.
Thank you so much, Jhie. I'm so glad you were able to present after all, and you found some really constructive ways to get around some of those challenges and reduce the age of consent or have doctors provide consent for young people over age 15 to get testing and other services. So really practical solutions to the challenges faced by many young key populations. We've run over, but I think we've had a huge, rich discussion. We've had some wonderful examples of young people, how they've led community-based responses, how we've had allied health services that are user-friendly and key population-friendly. We've seen the hybrid model of drop-in centers and fixed site clinics and virtual platforms and social media, as well as peer educators going out into the community. We've heard about the need for continued funding, and the Global Fund is there. We hope to get many key population organizations funded in the next round, but we also have to think more about domestic funding for the key populations, and this social contracting model I think is very important for domestic governments to provide funds to non-government providers who are trusted by the community. I just want to add one more thing that I think is important that I haven't heard through the discussion, and that's our comprehensive sexuality education. We now have guidance for delivering CSE out of school sessions and out of school settings. And I think this is directly relevant for many young key populations who, for whatever reason, are not attending school. So we can now deliver CSE in the community settings, be in a drop-in center or under a tree or wherever young people congregate, and we can spend more time and go into more detail. So in some ways, the out-of-school CSE is in a way better than the in-school in some respects. I want to thank all of the presenters, and as has been said, the recording will be available and the presentations, so you will be able to consider them further. And we look forward to hearing in future about more engagement of young key populations and more young key population organizations leading their own responses. So I wish you all well, and we look forward to seeing you at our next session, which we will announce later in the year. Thank you so much, and goodbye.
Thanks, Tim. Thanks, everyone. Thanks for inviting us.